Hello, everyone. I'm Dr. Asma Nazir, one of the mentor of Study MRCPI. I'm here to discuss few of the topics regarding the written MRCPI. And this is the YouTube series, which is you guys find helpful for the preparation of the exam. Today's the topic is the postpartum. So we are going to cover all the topics, the few important topics we are going to cover, which is third degree and fourth degree perineal tear repair. We are going to cover the postpartum hemorrhage, blood transfusion in obstetrics, and the neonatal resuscitation. Hope you guys find it helpful. Let's start. There are some few questions I'm sharing with you, and then the important flash points which are important to remember for these topics. So let's start with the third degree and fourth degree post perineal tear repair. So first of all, the quote of the day. So ambition is the path to success. Persistence is the vehicle you arrive in. Let's start. Yes. So the first question is that you are asked to assess a woman's perineum after a vaginal delivery. There is an extensive tear disrupting superficial perineal muscles and 70% of the external anal sphincter torn. There is no disruption of the internal anal sphincter. How would you classify this perineal trauma? So before answering, read the question carefully twice and then go for the options. The first is second degree tear, 3A tear. It could be 3B tear, 3C tear, or a fourth degree tear. So everybody who is going to sit in the exam must know about the classification. So what is the answer? When there is a more than 50% of the external anal sphincter is involved, we all know that it's 3B tear. So the answer is 3B tear. This is the classification. And I pasted here for the quick review. You can see the first degree tear means injury to the perineal skin and the vaginal mucosa. Second degree tear is injury to the perineum involving the perineal muscles, but not the anal sphincters. In third degree tear, the anal sphincter complex is involved, but it is further classified into three categories, 3A, B, and 3C. In 3A, there is less than 50% of the external anal sphincter involved. In 3B, more than 50% is torn. And in 3C, both external and internal anal sphincter torns. Fourth degree tear. In fourth degree tear, injury to the perineum involving the anal sphincter complex, which is the external anal, internal anal, and also the anorectal mucosa. Hope it finds helpful. Another question is, immediately after the diagnosis of the third and fourth degree tear, what should be the most appropriate next step? The most appropriate next step, we should have to recall our memory that when we are going to repair the third and fourth degree tear, what are the most appropriate next steps? So options are commence oral antibiotics, discharge with laxatives and follow up in 6 weeks, perform an immediate endoanal ultrasound, inform the consultant, and transfer the patient to the operating theater for repair. So you have to choose the option carefully after reading the question that what is the most appropriate step when you are going to deliver the patient and you find that patient is having a third or fourth degree tear repair. What you have to do? Let's move on to the answer. Yes, the answer is that we have to inform the consultant. And this is the reference for the answer taken from the Irish guideline. You can see here that whenever we have to diagnose the tear, it has to be repaired by the trained personnel, and we have to inform the consultant immediately because it needs to repair immediately. Next. A woman who sustained third or fourth degree tear should have follow-up postnatal visit. It's 6 weeks postnatal, 6 months postpartum, 1 to 2 months postnatal, within 2 to 3 weeks postnatal by public health nurse, or only when she reports symptoms. Let's move on to the answer. So, answer is that within 2 to 3 weeks by the public health nurse. This is the flow chart, which is very important to have a look into it. It is a very important chart, which tells us when we have to follow the patient. This is the management of the obstetric inner sphincter following discharge from the hospital. Public health nurse woman should take care of the woman's wound care and routine postpartum care. She should visit the patient by 2 to 3 weeks. She will ask for the symptoms. If there is any need to go to the consultant, she will refer the patient. The obstetrician visit by 6 to 12 weeks. Then again at public health nurse again visit the patient at 8 weeks onwards. If there are symptoms, then she refer the patient to the colorectal surgeon or the obstetrician. And then again 3 months review by the consultant. The woman should be asked for the symptoms. What if she's asymptomatic, then we have to discharge. If there are symptoms, then we have to refer the patient to the colorectal surgeon. So the next question is, what should be the essential post-operative management for a woman sustained obstetric anal sphincter injury repair? It includes laxatives and stool softeners, antibiotics, avoid intercourse, analgesia only, or bed rest for 48 hours. So the answer is that patients should use laxatives and stool softeners because this is a very important part of the post-operative management. It is a very effective. Patient should need obviously antibiotics and analgesics, but the laxatives and the stool softeners are very important part for the repair of the obstetric anal sphincter injury, because we need to soften the stool so it is not going to disrupt the perineum or the wound adhesions. So let's all move to the next question. What's the role of physiotherapy in the recovery from 3rd or 4th degree tear repair? To strengthen the pelvic floor muscles and improve the bowel and bladder control, to reduce the pain and inflammation in the perineal area, to promote wound healing, to prevent infection, or to help with psychological recovery from the birth experience. Again, I am going to say that we have to read the questions carefully, twice at least. So we should not going on to end up by giving a wrong answer. Let's move on to the answer. The answer is that we have to strengthen the pelvic floor muscles and improve the bowel and the bladder control. So pelvic floor exercises is very important for these purposes. This is the reference taken from the Irish guideline. You can have a look into it, that we have to strengthen the pelvic floor muscles by doing the pelvic floor exercises. These are some important charts which has been taken from the Irish guideline. And it is important to review that this is a recommended care pathway for the management of obstetric anal sphincter repair injury. Post-repair, what we have to do, what is the management prior to the discharge from the hospital. It is very important that we have to tell the patient about the postnatal care, the hygiene, and about the perineal care. These advices has to be given by the midwife. Then laxatives should be prescribed to the patient, broad spectrum antibiotics, and we have to arrange the postnatal follow-up. And in the ward, we have to call the physiotherapists. They will educate the patient about the pelvic floor anatomy and and they visually inspect the perineum with the consent of the patient. And we have to tell the patient regarding the pelvic floor exercises. We have to encourage the good bowel and the bladder habits. We have to teach the patient about the manual support of the perineum with defecation and intra-abdominal pressure. We teach the patient about the pelvic floor exercises and sphincter exercises. And we also provide the patient information leaflet, and we tell the patient that at every time if she feels any discomfort or anything which is not comfortable for her, she immediately report to the hospital or the physiotherapist. So this is the pathway for the management of the obstetric anal sphincter injury. So how we have to manage the patient after the repair. As we told you that it is important for the patient to be followed up by the public health nurse within 2 to 3 weeks after the discharge from the hospital, to review the patient, to ask her the symptoms, to check the perineum. And at 6 to 12 weeks, it is reviewed by the consultant. Then 8 weeks review by the public health nurse. Again, at the 8 weeks, if there is any symptom, they have to refer the patient to the obstetrician. If all is going fine, then there should be 3 to 4 months review by the obstetrician. And if the patient is asymptomatic, then we have to discharge the patient from the follow-up. And if there is any problem, then we have to refer the patient to the colorectal surgeons or the specialist gynecologists who can make necessary arrangements if it is required. So now we are going to cover a few questions from the postpartum hemorrhage. First question is that 35-year-old grand multi has had major PPH following a normal vaginal delivery. Mechanical and pharmacological measures have failed to control the bleeding. Examination has confirmed that there are no retained placental tissue in the uterine cavity and the absence of the trauma to the genital tract. What is the most appropriate first-line surgical management? So, is it an option A, B-Lynch or modified compression sutures, balloon tamponade, ligation of the internal iliac artery, postpartum hysterectomy, or selective arterial embolization? So whenever we are going to manage or dealing with the questions of the postpartum hemorrhage, it is important to review all the options of the management, that what we are going to do in the medical method or in the pharmacological methods, and if they are not going to be helpful, then what is the first surgical management? I hope all of you aware about it, that it's balloon tamponade, which is the first surgical management of the postpartum hemorrhage. And it is taken from the reference has been taken from the Green Top guideline, that it is the most appropriate first-line surgical intervention for most of the women if uterine atony is the main cause of the hemorrhage. So next is, what is the active management of the third stage of labor and how it reduces the risk of PPH? By what proportion is the risk of PPH reduced by the prophylactic oxytocic agents? Is it 30%, 40%, 50%, 60%, 80%? Yes, the most of the time the percentages are not going to be asked in the MRCPI exam, but few important percentages are important to know, and this is an important one. So active management of the third stage of the labor reduces the risk of postpartum hemorrhage by about how much? So let's see the answer. It's 60%. The reference has been taken from the Green Top guideline, and it is also mentioned in the Irish guideline, which is the 2024 guideline of postpartum hemorrhage. So move on to the next question. In PPH, which of the following is correct? A blood loss of over 40% of the total blood volume of a 70 kg woman is considered life-threatening. Option B, during cesarean section, it is routine practice to administer a slow IV dose of 10 international units of oxytocin as a prophylactic measure to reduce the risk of PPH. Argometrine is absolutely contraindicated in the management of severe PPH in women who is known to have had hypertension in pregnancy. Misoprostol have been shown to be as effective as oxytocin in the management of PPH. Prophylactic oxytocins given routinely in the management of third stage of labor reduces the risk of postpartum hemorrhage in more than 90% of cases. So these are the options. Let's move on to the answer, that what is correct. The option A is the right answer, which shows that blood loss of over 40% of the total blood volume of a 70 kg woman is considered life-threatening. So the answer has been taken from the RCPI and RCOG guideline both. As we can see here that a blood loss of more than 40% of the total blood volume, which is approximately 2,800 ml, is generally regarded as life-threatening. And how much, as we discussed before in the previous slide, that prophylactic oxytocics in the routine management of the third stage of labor reduces the risk of PPH by about 60%. And for all the women who are delivering by C-section, 5 international units of the oxytocin by slow IV injection should be used to encourage the contraction of the uterus and to decrease the blood loss. Move on to the next question. Which of the following is not a component of the 4 T's mnemonic for the PPH causes? Tone, option B, trauma, option C, thrombin, option D, temperature, option E, tissue. So we should remember the 4 T's. Move on to the answer. Yes, it's option D. Temperature is not the part of 4 T's. These are the causes of the PPH. So must go through all of these. These are very important causes. These are very important to know that what are the options for the tone, tissue, trauma, and the thrombin. This is very important to review. Tone means abnormalities of the uterine contraction, which is the overdistension of the uterus. It could be caused by polyhydramnios, multiple gestation, macrosomia, intraamniotic infection also leads to the loss of tone. which is fever, prolonged rupture of the membranes, anatomic distortion of the uterus, rapid labor, prolonged labor, fibroids, placenta, previa, uterine anomalies, and uterine laxants. If patient have been given uterine laxants, for example, magnesium and nifedipine, terbutaline, halogenated anesthetics, glycerol nitrate, bladder distension, it may prevent the uterine contraction. And the next T is tissue, which is the retained products of conception. Trauma, if there are any genital tract injury, regarding lacerations of the cervix, vagina, perineum, extensions, lacerations at C-section, uterine rupture or uterine inversion. These can happen because of the precipitous delivery or operative delivery, malposition, deep engagement, previous uterine surgery, high parity with excessive contraction. So, and thrombin means any abnormalities of coagulation, like in patients of hemophilia A, ITP, von Willebrand disease. So it is important to know the risk factors because the questions can come from any view. Next question is, according to the RCPI, when should a massive transfusion protocol should be activated for the PPH? If the blood loss is more than 500 ml, the blood loss is more than 1500 ml or hemodynamic instability, only if the hemoglobin is less than 7 gram per deciliter, or only in cases of placental abruption, option E, if the blood loss is more than 1000 ml. So when we are going to activate the massive transfusion protocol, let's move on to the answer. If the blood loss is more than 1500 ml or the patient is hemodynamically unstable, then we have to activate the massive transfusion protocol. This is the reference has been taken from the latest guideline of the RCPI for the management of the PPH. You can see here, this is the major obstetric hemorrhage protocol. ODED obstetrics should be activated for uncontrolled bleeding more than 1500 ml blood loss, or if a clinical concern warrants it. So each maternity unit should adopt the nationally agreed term life-threatening hemorrhage coded obstetrics when the blood loss is more than 1500 ml or patient is hemodynamically unstable. These are the few important points regarding the management of the patients we are dealing with the postpartum hemorrhage. Everybody should know about this. This is the medical treatment, what we have to do. Medically, we have to treat the patient. We have to, whenever the patient, we have this postpartum hemorrhage emergency, we have to immediately rub up the uterine fundus, or we have to put the hand over the fundus to check whether the uterus is contracted or not. If the bladder is not emptied, we have to empty the bladder, give the patients 5 international units of syntocinon, slow IV, and repeat if it is necessary. If the patient is not hypertensive, then we can go for the symptometrine. If it is not helpful, then carboprost. We can repeat it every 15 minutes up to 8 times. And we can also give it intramyometrial. It provides a very good contraction. Or misoprostol. This carboprost is PGF2 alpha. Before giving to the patient, it is important to know that patient should not be asthmatic. We can try it with the 800 microgram of the misoprostol sublingually, or we can also consider the tranexamic acid. If they are not going to be helpful, then we have to move the patient to the theater to check that is the uterus is contracted. Examination under anesthesia should have to be done. Is there any clotting abnormality which needs to be corrected? For surgical management, as we discussed, we have to try with, if these measures are not going to be helpful, we have to go for balloon tamponade, not helpful, brace sutures, interventional radiology. And if we are going to move on to the open the patient, then we have to first step is we have to do the uterine devascularization, bilateral internodiac ligation, hysterectomy, uterine artery embolization. And what is our therapeutic goal for the massive blood transfusion? The hemoglobin should be more than 80 gram per liter. Platelet count should be more than 50,000. PT-APTT should be less than 11.5 times of the normal, and fibrinogen should be more than 2 gram per liter. These are some important protocols have been taken from the RCPI guideline, that what we have to do when the blood loss is more than 500 ml, we have to take the help. We have to act, we have to measure the patient vitals, secure the IV access, we have to take samples for the full blood count, antibody screening, PT-APTT, record the patient's cumulative blood loss, and we have to treat the patient, massage the uterus, expel the clots, give uterotonics, empty the bladder, inspect the genital tract, and confirm that placenta and membranes are complete, commence warm crystalloid infusion. This is a stage 2, what we have to do when 1 liter, there is a 1 liter blood loss. We have to go through the same protocols, just we have to insert a catheter after emptying the bladder. If we did not catheterize the patient, we have to catheterize the patient. We have to do the bimanual compression. We have to try with the tranexamic acid, and we also have to start transfusing the red cell components as appropriate. And if the blood loss is more than 1500 ml, as we mentioned before, that we have to go for the coded obstetrics massive hemorrhage protocol we have to follow, and we have to review the treatment, uterotonics. If we need to go for the advanced surgical techniques to stop the bleeding, we have to go ahead, consider repeat tranexamic acid, and we have to rule out the causes. And this is an again important chart which has been taken from the RCPI guideline. It is important to go through. It is very helpful in the exam to solve the questions and also for the OSCE as well. So just go through it. These are all the slides which we have been discussed before. Now the blood transfusion in obstetrics, this is also a very important topic. Few of the questions regarding it. The first question is that hospital blood transfusion committee requires guidance with regard to the use of cell salvage in obstetrics. On which occasion of the cesarean section, cell salvage is recommended? Only for the women who reject the use of the blood products. Option B, when intraoperative blood loss is anticipated to be greater than 1000 ml. Option C, when intraoperative blood loss is anticipated to be greater than 1500 ml, or when there is a high risk of platelet dysfunction, or when there is an anticipated coagulopathy. So the answer is when there is intraoperative blood loss is anticipated to be greater than 1500 ml. So this is the reference which has been taken from the Green Top guideline of blood transfusion in obstetrics. It is recommended for whom intraoperative blood loss is more than 1500 ml. Second question regarding this. In case of massive obstetric hemorrhage, above what level should fibrinogen be maintained? We just have gone through the in postpartum hemorrhage also, that in case of massive obstetric hemorrhage, at what level we have to maintain the fibrinogen levels. Let's see the options. Option A is 0.5 gram per liter, B is 1 gram per liter, option C 2 gram per liter, D is 5 gram per liter, or E is option E is 10 gram per liter. So as we all know that it should be more than 1 gram per liter. Blood transfusion in obstetrics, fibrinogen level should be maintained above 1 gram per liter by the use of FFP as above, or by the use of 2 pools of cryoprecipitate. This is the right answer. The reference has been taken from the blood transfusion in obstetrics. Another question is a Jehovah's Witness, which is a very important topic. The Jehovah's Witness patient at 32 weeks of gestation has a hemoglobin of 55 gram per liter due to iron deficiency. She refuses blood transfusion but accepts the iron therapy. So what is the most appropriate action for these patients? Option A, admit for urgent transfusion. Option B, respect her autonomy and optimize the non-transfusion management. Option C, transfuse covertly during anesthesia. And option D, obtain a court order to override her refusal. Option E, administer erythropoietin alone. So let's check what is the answer. Option B, which is we have to respect the patient's autonomy and optimize non-transfusion management. So it is important to ask from the patient that which kind of the blood product she is going to admit and which she is strictly refused for that. So this reference has been taken from the Green Top guideline. Next question is, 32-year-old woman at 38 weeks of gestation has a postpartum hemorrhage of 1500 ml following vaginal delivery. She's asymptomatic, normotensive with a heart rate of 85 beats per minute, and her hemoglobin is 75 gram per liter. What is the most appropriate immediate management? We have to transfuse 2 units of packed cells immediately, administer IV iron therapy, transfuse 1 unit of packed red cells and recheck the hemoglobin. Option D, observe clinically and repeat hemoglobin in 24 hours, or we have to give a human recombinant erythropoietin. So let's move on to the answer, that we have to observe the patient clinically and repeat hemoglobin in 24 hours. The reference of this is mentioned here. I have taken the reference from the Green Top guideline of blood transfusion in obstetrics. It is important to go through this guideline. Please, guys, go ahead with this guideline. Next question is, a woman with placental abruption has an estimated blood loss of 2000 ml. Her hemoglobin is 65 gram per liter and she is symptomatic, tachycardic, pale, oliguric. What hemoglobin threshold warrants the red cell transfusion? Option A, hemoglobin less than 60. Option B, hemoglobin less than 90 gram. Option C, hemoglobin less than 80 gram per liter. Option D, hemoglobin less than 70 gram per liter. Or we have to transfuse the patients based on the symptoms alone, regardless of hemoglobin, as we are going to treat the patient, not the labs. So move on to the answer. Right answer is we have to transfuse the patient based on the symptoms alone, regardless of hemoglobin. And look, there is a reference which has been taken from the Green Top guideline. And these are some important slides which are important to go through regarding the patient management, that in pregnancy at less than 34 weeks, what we have to do if hemoglobin is less than 5 with or without signs of cardiac failure or hemoglobin, what we have to do when we have to consider the blood transfusion in the patients. You can go through these slides. These are very important for the exam preparation. I have added here. So what are our goals? Our goal is we have to blood transfuse the patient. We have to keep the patient hemoglobin more than 8 gram. We have to play for platelets to keep more than 50,000. We have to transfuse the patient platelets when it is less than 75,000. So we have to maintain the platelets more than 50,000, and we have to keep the fibrinogen more than 2 gram. PT and ABT should be less than 1.5 times of normal. So keep them in this range. It is important. We have to transfuse the FFPs at a rate of 12 to 15 milliliter per kg. So now the last topic, it's neonatal resuscitation. So this is an important chart for the neonatal resuscitation, that antenatal counseling, team briefing, equipment check. It is important at the time of the birth. It is important to check that at what gestation patient has been delivered, and what about the baby's tone? Is it good or not? Baby's crying or breathing? If yes, baby's crying, then we have to keep the baby warm with the mother for routine care. If baby is not, any of thing is not good, the tone is not good, baby is not breathing or baby is not crying, then we have to immediately keep the baby warm, maintain the normal temperature. We have to position the airway, clear the secretions. If needed, we have to dry the baby and stimulate. We have to check whether baby is apneic or gasping or heart rate is below 100 per minute. If it is not like this, there's only labored breathing or persistent cyanosis, then we have to just clear the airway, check the oxygen saturation. We have to supplement oxygen as needed and consider the positive air pressure ventilation. So if baby is apneic or gasping and heart rate is also below 100 per minute, so we have to start positive pressure ventilation. We have to check the oxygen saturation, monitor the baby, consider ECG monitor. We have, after these things, after 1 minute, we have to repeat our assessment. If it is still heart rate is below 100 per minute, if it is not like that, we have to continue with the post-resuscitation care debriefing. And if it is heart rate is below 100 per minute, we have to check the chest movements, ventilation corrective steps we have to take in. We have to pass the ETT if it is required. So now we have to check again the heart rate. If it is below 60 per minute, yes, we have to intubate. If not already done, we have to start the chest compressions, continue with the positive pressure ventilation, give 100% oxygen, and consider emergency. And if heart rate is still below 60 per minute, then we have to consider the drugs, IV epinephrine. If heart rate is persistently below 60 per minute, consider hypovolemia and consider the pneumothorax. Initial evaluation, what we have to do, as we said that after the birth, we have to check at what gestation patient has been delivered. Is it term or not? What is the tone of the baby? Baby is breathing or crying or not? So we have to stay, if the baby is fine, baby is crying, and there is a baby's breathing as well. So we have to continue the routine care. We have to keep the baby warm, maintain the normal temperature, position airway, clear secretions. If needed, we have to dry the baby and stimulate. What are the initial resuscitation steps? We have to keep the baby dry, keep baby warm, sniffing position, suction. If intubation not required, just for the presence of the meconium, we have to do the suction, and we have to stimulate the baby if baby is not crying. Cord clamping should be delayed for at least 30 to 60 seconds for most vigorous term and preterm newborns. These are some important steps. Is how we have to put the mask. This is the correct position is this. These are the wrong ones. This is some important steps. You have to go through it. These are important to answer the questions of the neonatal resuscitation. So how we have to hold the baby for the chest compressions. Look at this. And now the questions. What is the first action on commencing resuscitation of a newborn baby? Option A, follow the ABC approach. Option B, try and cover the baby. Option C, commence the chest compression. Or option D, insert a Gordon airway. So yes, we want the answer. As we have gone through the slides and the charts, important charts, so we know what is the right answer. Right answer is we have to dry the baby and cover the baby. This all is taken from the neonatal resuscitation. Next question is the most useful initial assessment of the newborn infants, including which of the following? Is it tone, heart rate, tone, breathing and heart rate, color of the baby and Apgar score? Very important to go through the question. Okay, most of the people answer Apgar score. Yes, it is important to assess, but it is not an accurate one. So as we have just gone through the chart, so what is the right answer? Let's see. Option C. So it's option C, tone, breathing, and heart rate. I write the option right, but here I forget to amend. It's not Apgar score, it's tone, breathing, and heart rate. It's not Apgar score. Another question is, if a newborn's baby heart rate falls or fails to respond following 5 inflation beats, what should be done? We have to commence chest compressions. We have to insert an umbilical venous catheter. We have to recheck the airway, or we have to insert an endotracheal tube. So whenever it is like so, what we have to do? We have to recheck the airway. Moving on to the ETT. Before moving on to the ETT, we have to first recheck the airway. Next question is, during the resuscitation of the newborn procedure, what should the healthcare team do? Option A, keep parents informed of what is happening to their baby. Option B, withhold information from the parents until the resuscitation event has finished. Option C, prevent the baby's parents from watching resuscitation taking place. Let's move on to the answer. Right answer is, parents should be informed what is happening to their baby. This is the reference in which it is written that all information needs to be primarily communicated to the parents. They were not expecting anything to go wrong. They will be anxious and need reassurance that help is being given to their baby. If resuscitation is unsuccessful, they will need to know what has been done and if the baby needs to be transferred to the neonatal unit or not. Keep information factual, and guessing the possible outcome is not helpful. Another question is, where should pressure be applied when performing the compressions on the newborn? Option A, lower third of the sternum. Option B, upper third of the sternum. Option C, over the xiphoid process. Option D, any of the above sites are acceptable. So yes, it's lower third of the sternum. As you check on the slide also as well, I can show you again. Look, this is the lower third of the sternum where we are going to give the compressions. So that's all for the postpartum topic. These are the few topics which we have been covered. If there are any questions, any queries regarding this, please drop down in the comments. We are here to answer. Keep practicing and best of luck.